Here we present a technique for medial patellotibial ligament reconstruction in pediatric and adolescent patients with patellofemoral instability. The authors report no relevant disclosures. Patellofemoral instability and acute patellar dislocations are common injuries in the pediatric and adolescent population. We believe that medial patellotibial ligament reconstruction is an important adjunctive procedure to medial patellofemoral ligament reconstruction in certain patients undergoing surgery for patellofemoral instability. The MPFL acts as the primary restraint to patellar lateralization during initial knee flexion from 0 to 30 degrees, contributing approximately 50% of control in deeper knee flexion. The MPTL contributes 30% of lateral restraint from 0 to 30 degrees of knee flexion, contributing up to 50% in deep knee flexion. After approximately 30 to 40 degrees of knee flexion, the MPFL and MPTL work together to control lateral patellar translation. Several prior articles have been published describing MPTL reconstruction techniques. However, these have been largely for patients who've achieved skeletal maturity and have included both anatomic and transpatellar reconstruction approaches. The purpose of this article is to describe our preferred surgical technique for pediatric and adolescent anatomic MPTL reconstruction with a specific focus on our physeal-sparing approach to avoid postoperative growth deformity. We show here images and videos of two cases of patients undergoing combined MPFL and MPTL reconstruction. The case begins with a diagnostic knee arthroscopy, depending on surgeon preference. Otherwise, anatomic landmarks including the patella and tibial tubercle are marked. A midline incision is made, keeping in mind the potential for future knee arthroplasty. After initial dissection, the planned site of the tibial limb for the MPTL reconstruction is identified in the proximal tibial epiphysis. This is located approximately 1 centimeter distal to the joint line and in line with the medial edge of the medial tibial spine, approximately 1 to 2 centimeters medial to the tibial tubercle. This is then marked with either a 1.25 or 1.6 millimeter K-wire and confirmed fluoroscopically. Once confirmed, this area is debrided of soft tissue and decorticated with a burr or rongeur to a bleeding subchondral bone for graft healing. Dependent on patient size, a 1.8 or 2.6 millimeter Arthrex FiberTech knotless suture anchor is then placed into the proximal tibia. A hamstrings allograft greater than 15 centimeters in length and typically 4 to 6 millimeters in diameter is first placed through the tibial anchor loop and secured to the epiphysis. Additional backup fixation is obtained by suturing the graft using an absorbable braided suture to the robust periosteum of the proximal tibia. The free end of the graft is then tunneled beneath the medial retinaculum and brought out through a small opening at the inframedial aspect of the patella near the planned placement of the patellar anchor. Similar steps are then repeated for the patella, and a 1.8 millimeter Arthrex knotless FiberTech anchor is placed at its inframedial aspect. The free end of the graft is then placed through the patellar FiberTech and secured in approximately 60 degrees of knee flexion to ensure appropriate residual patellar mobility without over-constraining patellar motion. The patellar end of the graft can then similarly be reinforced by suturing onto itself and the medial retinaculum and patellar tendon using a 2-0 fiber wire stitch. Any excess graft can then be excised. At this stage, the knee is taken through a full range of motion with confirmation of near normal patellar tracking confirmed. Dependent on concomitant procedures, patients are typically made toe-touch weight bearing after surgery, with range of motion from 0 to 90 degrees, locked in extension for ambulation. A continuous passive motion machine, starting at 0 to 30 degrees, is initiated on postoperative day 3. Advancing range of motion is tolerated, with a goal of full range of motion 6 weeks after surgery.